All right, I think we'll go ahead and get started. My name is Rui Carrasco. I'm a pediatric rheumatologist here at Dell Children's. And unfortunately, I'm the only one, but I'm still having a lot of fun. And so this time, there are no slides, there's no handouts. It's just an interaction. This is about how to talk to your doctor. And I'm going to tell you two stories about the way I think of this in terms of medicine. When I was a pediatric resident, it was my first year, and we were able to pick different clinics where we could go to learn medicine. And what we did is we picked a clinic, and we'd be there at that clinic for 3 years. And there was one clinic where everybody wanted to be at this clinic because this person was amazing. He was a Dominican doctor, and he was like a Patch Adams version of a doctor. And at that clinic, just to give you an idea of why people loved him so much, is I remember the first time I went into a room with him, it was just a well-child visit. And he goes in there, he's smiling, he's about 6'4", so he's this tall guy who's probably about 125 pounds. So he's this tall, really thin guy with this really curly, poofy hair, and it's almost touching the door entrance. So you kind of imagine this kind of goofy-looking doctor who's going in, and he grabs the baby out of this mom's arms, and he hugs the baby and just squeezes her, and he tells us, "This is the most beautiful baby." He squeezes her, and the mom tells him, "I bet you tell that to all the moms." And he says, "You are absolutely correct. And every time I say it, I mean it." And I remember when we left the room, I said, "Oh, that was a good one. She caught you telling her that you tell that to everybody." He says, "But Rui, every time I say it, I really mean it. And when I go into that room, the most important person is the patient, and then because we're in pediatrics, it's the patient and the parents. And if you can remember that," I said, you'll go on to do great things." And I think it's really helpful when you have that type of mindset in terms of talking to your doctor. There have been several studies looking at interactions with patients and their families, and who are the happiest patients. And those patients are the ones that feel that their doctor has empathy for what they're going through. And so there are some new tools that are available so that you can rate us in terms of our empathy. And so when I went through this, I was like, wow, what's really helpful for me in terms of being prepared? About 4 years ago, my wife and I had to go through some not so fun things with my son in terms of treatments. And we had to go in, we had to spend the night for about 3 nights. And we had to decide. I remember the doctor came in and said, "All right, your son has this condition, and you have to take this medication." And I remember it took my wife about 0.2 seconds to decide about taking that medication. And I remember the interactions that we had with the staff, the interactions that we had with the cleaning staff, which is funny as that sounds, and the interactions that we had with the doctor. And some of the richest interactions were not with the doctors, but with the staff, the people who brought us our food, the people who cleaned. And I was thinking, wow, it's kind of sad that the best interactions we had were not the healthcare providers. And it reminded me of the humanity of medicine and to not be that way. And I remember recently we had to go, since my daughter had her 4th fracture, to go to orthopedics. And the orthopedic doctor, the first one that we saw, the interaction was very different. And as soon as the doctor left, my wife says, "You see that? That's exactly what you don't do. I don't ever want to hear that you did that." Sort of like when I leave the house, my wife always makes sure that I'm dressed fine so that I don't embarrass her. That was the same way in terms of that interaction, not to embarrass her. And at the time, it was really relevant because she was working at the Children's Hospital, and her friends would always give her feedback of how I acted. So before I go on, is there any questions about how to talk to your doctor? About October, before my colleague left, we had some negative comments that were left on the internet regarding our clinic. And so what we did in our clinic is we decided that instead of saying, well, this is a problem of one person, meaning of a provider, it's not a problem of the clinic, we decided that it reflects the whole clinic. And so what we did is we met with the Arthritis Foundation at the national level and at the local level. We said, all right, tell us how you think we interact with you and how we can do a better job. Tell us the good, the bad, and the ugly. Feel free to use any language you want. Feel free to tell us anything that you want. And it was very telling. Part of the way that we're graded in medicine is patients do surveys. And when they do these surveys, part of what they ask is the interactions. Unfortunately, when these surveys were created, the mindset of the people who created them was on risk management. What can we do so that we don't get sued? So if you think about that, it already tells you that the surveys that us as doctors are getting are kind of screwed up. And unfortunately, we haven't moved too far away from those types of surveys. So when I was in Cincinnati Children's Hospital, every 3 months we met with families. We would meet with them, we'd take them out to dinner, we'd meet with them for about 3 hours, and we would say, what works in clinic, what doesn't. They would fill out surveys as well. And the most rewarding and most useful part of making a difference in our clinic was the stuff in between. The stuff that wasn't in the survey, because you can't sort of capture that. You can't really capture empathy. With the tools regarding empathy are newer tools that weren't available at the time. And so I thought those was some of the most rewarding and rich stories in terms of what we need to do better in terms of medicine. When I was at Cincinnati Children's Hospital, they spent over $2 million trying to get a $50,000 grant. And the grant was the quality of the care that they provide. And I couldn't understand, why is it that we're going to spend over $2 million? And what they said was, it's not the money that's important, because we're spending over $2 million, but it is what we're learning from our families about how we can do a better job. And so we do surveys in our clinic because the bean counters say that we're supposed to, and our ratings are 97, 98%, which is fine. I still think there's a lot of baloney. I like it when parents fill out the stuff in between it. I remember one patient, the mom was filling out the survey, and one of the things I don't like about the surveys is the parents often fill them out in front of us. I wish they were sort of separated so we never saw them. But this mom filled it out, and everything she filled out was in terms of, were they courteous, did they greet you, and everything was not always. And she circled the last one just really hard, and I said, boy, you really like that one. And I said, is there anything in particular that really, in that survey, because they were really asking questions about how was her service today. And she said, I think never, for what was really the answer that she filled out. And I said, may I ask you why you felt that you've never been seen on time, you've never been no one's ever talked to you with saying your first name or really addressed your questions in a timely manner. And she said, well, it's not your clinic that's the issue, it's all the other clinics, but this is the only way I can get this message across, that you guys suck. And by that, I was like, I think that's a very powerful message. And I think you can sell a better message. I said, if you write down what it is that didn't work, whether it was my clinic or any other clinic, and she did. And so then what we did is we took that, and I took it to the operations manager, and we worked on terms of those things that she had. One of those items that the families that she wanted, and that other families, when we met with the Arthritis Foundation, what they wanted was, let me see how this mom and dad said it best. They said, we aren't going to require anything from you that we aren't willing to do ourselves. In terms of we'll show up on time if you try to show up on time when you're supposed to see us. And it was really simple things that I thought were really helpful. When we come in, smile. Even if you've had a bad day, I've probably had a worse day because I have a child with a chronic condition. So just try to smile. And it was really, part of what we did in our clinic as a result of that, we ended up moving a couple of staff members out of our clinic they were probably not the most cheerful people, and so they moved on. And I think it hurt our clinic in terms of staffing, but it really helped us in terms of patient satisfaction. So are there any questions in terms of how to talk to us? Because I think sometimes we get lost in our own minds and our own craziness in terms of as physicians, and doesn't necessarily sell the same story for you as parents. Yes, Meg.
What about in a time or in a conversation with a doctor where you don't feel validated? How, as a parent, how do you bridge that gap so they do have empathy and you hope they're hearing you rather than just checking off a list and writing in a
Can you say your name and then state the question?
Yes, my name is Mary. Just when you don't feel validated, how do you bridge that gap to make sure that you feel heard and that they're not just, passing you off because everything's okay?
That's a great comment or a great question, and I'll tell you about something that happened to me on Thursday. On Thursday, I had the first morning patient. She showed up, I think, about 15 minutes early. I saw her about, I don't know, a little before 8. And she had her arms crossed, and I said, "You look like you're not having a great day," after I shook their hands and said hi to everyone. And she's like, "I'm not. I don't think your clinic and you are providing the care that I need." And so I immediately said, "All right, why don't we put aside the clinic stuff and let's talk about what your concerns are." And I think that really helped to understand what she was going through. And she was upset with our clinic because what she wanted was me to get her, I think she'd called 2 days earlier and wanted me to get her the medical records when she showed up to the clinic. And unfortunately, I wish I could give her the medical records, but I'm not the medical records department. She was also upset because there was a referral that was done that has to go through the primary care doctor, but she wanted me to do it. But unfortunately, the way her insurance worked was it had to go through the primary care doctor. So I think part of it was hearing that story and being able to tell that story to the doctor and sort of making them take a time out. And that's what we ended up doing with that clinic. And when she left, she left really happy. But part of it was because we found, in medicine, we call it the hidden agenda, which I think is a terrible label. But I think what it should really be called is the real story. What's really happening with the family so that we can get a better idea. I remember when I was in medical school, what we learned in medical school was that some of the most unimportant people are the healthcare providers, because there's all this stuff that happens at the home that's much more important than what the doctor tells you. He tells you to take this medication. And maybe you don't have a refrigerator. I remember a patient who when I was telling her, "You're going to take these 2 medications, and this is the way you're going to take it, and this is why you have to store it here." And she said, "And where the blink do you want me to keep these medications?" And I was like, "Well, where most people keep it, in the refrigerator." And she said, "I'm homeless. I don't have it." And so until I was able to validate her story and sort of take a time out, I would never have been able to sort of find that out, because I had to delve in that. So that 30-minute appointment turned into about a 2-hour visit, and so we had to get a lot of people involved. So I think part of what the way I would approach that is probably, if you're not being able to get heard, one of the most useful ways when patients don't feel that in my clinic is what we try to set aside an appointment just for the parent, or just to discuss sort of the non-clinical stuff that's really helpful. And what some parents have done sort of to get the story in is we have a patient portal. And so I hate patient portals because I got 3 of them, and they're like belly buttons. Everyone has one, meaning every practice has one. In my system, we're trying to get those so that they're consolidated, but that may be another way so that you can try to get heard and get validated in terms of, like, listen, I've got these concerns, even if those concerns are with the doctor or with the clinic or with the refills, whatever it is, and until you sort of force the system to stop to hear you, they're not going to. Because in our minds, we come in and like, all right, I got to hear the story really quickly, I got to move on, I've got to see 5 more patients before the morning goes. So you've got to stop them. Let me get you the mic. Tell us your name, where you're located, and your question.
I'm Sheila Harvey. We're located in South Louisiana. We've seen our local doctors, which we don't have very many pediatric rheumatologists, so we have also traveled to other clinics in other states to see some of the research doctors and things. But one of the things, and we're just grandparents, and this is all of us, but we all go. So we all go to an appointment. So we've gotten the feeling, for some people, I'm sure, and you can tell as a doctor, that it could be a little intimidating when you walk in a room and there's 4 of us in there, but we all have a job, okay?
Correct.
And so that's some of the areas we've had trouble with. We feel that there's a breakdown of that, because you coming in as a doctor are expecting maybe to just see the patient and the mother, and we're going to just get to the bottom of this. I have 4 other patients, and basically it's the doctor's agenda. And, we have traveled
Absolutely.
and spent 2 days before and flights and hotels and whatnot to get to see you. And so, he's here to entertain her so that the mother can download that information. And I'm sort of a statusist, so I'm listening and kind of afterwards can help disseminate all the information. So how would you, if this were to happen to you, like what is a suggestion? Is there something we can do before? Is there something we can do during or after for this type of approach so that it's a good experience? We've had some good experience. Most of the time it's not, actually, because it's a crowded room and, it's just not a good
Specialists
situation.
only. I mean, they don't come to
Specialists.
every pediatrician appointment.
No, no. When we travel out of state or we do these important
Right.
pediatric rheumatology appointments are very important in her care. No, we don't go for everything. But do you have any suggestions for that? Do you know?
Should we
how
warn people?
Should we warn them? Should we get what you expect? I mean, it just seems like if there were more communication about expectations on both sides. Is that even practical?
Then that shouldn't, I don't think of it as practical. I think that's an expectation that you should have. There's AJ and her family back there, and
Yes.
I really look forward when they come in because I know it's going to be a group coming in, and it's such a nice experience to have them there, because part of it says this is an interested family. They want other people to be informed, because maybe the next time that AJ comes in, it may not be with mom, or it may be with grandmother instead. And so it's easier to have that type of connection. So I personally look forward to it. I think for me, it's one of the most disappointing that I would say if I look back at the last 100 visits that I have in clinic, that probably 90% of the time it's mom, it's someone other than dad. And so I think, one, you should expect, your doctor should be able to have whomever you want at the visit. And if you're going to have probably 6 people, maybe you should warn them so that maybe they put you in the bigger room if they have the ability to have your bigger room, or if they have a little conference room if you want to have it. And I think in terms of the connections, I think it really helps to have those types of connections where if you can have all the other people go who might be involved or who might call, so that if mom says, you know what, I'm going to have here, sign off a document that says grandmother is allowed to call and ask questions. Especially because now there's so many families who have made decisions regarding care and how they're going to get care, so they'll have 2 jobs. So both parents work, and so maybe it's only grandparents. So my big answer is your doctor should be okay with that. If not, then you should go somewhere else. Not that I'm telling you to leave your doctor, but... And then the other story is it's nice to have people there who aren't necessarily the parents, because it really tells you this is a family that's really interested. Because if I think about how many of the appointments I have, it's usually just mom or dad. So I'm not picking on dads because I'm a dad, but I usually get in trouble when I go to my kids' appointments because there are questions that I forgot to ask. And my wife's like, all right, she goes through her mental checklist of it. And I think having other people there is helpful.
Hi, I'm Kristen. I don't necessarily want them there in place of me. They don't ever make the bottom line decision, but they are my support in my real life and everything else. And we are very similar to Michelle and AJ in that it affects all of us, my husband, my other sibling, and we're a family.
Correct.
And so when I have to make the decision, because I make the bottom line decisions for all of it, just to be able to have the feedback, and I'm not superhuman. I'm not a doctor, and I have strengths and weaknesses, and she has strengths and weaknesses, and so it helps to have somebody else. So I would
Correct.
think that a doctor would appreciate that, but we have definitely run into not appreciating it. So
Because it's like when I have a patient with diagnosis X, and I have to tell them, like, all right, these are the medications that I'm thinking that you need to use, and if there's enough time, meaning their child isn't sick enough that I feel like you got to start treatment today, then what I'll tell them, I'll say, these are the drugs that you need to take, and these are the risks and benefits, and this is why I think you need to take it, and I want you to go home, and I want you to think about this, and at least for arthritis, what we have is we have a set of families who we tell them, all right, if you have any questions, I can't give you the patient perspective. I can't give you the mom or dad perspective or the grandparent perspective on what it's like to have a child with this particular condition. But we have people who can, and they can tell you what it's like to be the mom, dad, brother, sister, or the patient who has it, and they can tell you what it's like to be on drug ABC and what those side effects are, because I've never taken those drugs, and hopefully I never have to. And so I think that really helps in terms of doing that. So whether it's you calling or the grandparents calling, it allows you to have another resource. So I think it's helpful, and it's nice to have other people there. There's other families that bring other family members, and I think it's useful in many different ways.
And maybe, maybe we went about it wrong because, possibly if we would have identified, just like I just did, what each of our roles in that room are, that would have helped too. So
Correct.
I know that it's probably both sides, that we have some issues when we have issues. So, right now we're not having those current issues, but, just wondering from a doctor's perspective. So that's very refreshing to hear that you like to see that.
Correct. And again, it shouldn't just be me. I think it's everyone. You should have that expectation. I think if you have a family member who's a healthcare provider, it's very useful when the doctor comes in, or a nurse practitioner or whomever goes in, if you announce like, oh, we have my dad here who's a doctor, and so it'll be helpful, because I think it helps to enrich the conversations that you can have, because they can say, all right, well, in my experience with people who've taken blank drug, I've seen this. What do you think about it? Because it's in this disease or in this situation, in kids, because it's usually often an adult provider, an adult healthcare provider who may come in there. And I think that's been really helpful.
Yeah. Thank you.
Mary again. How far can we push as parents? If there's we obviously want our kids to be healthy now. We don't want to wait, but that's not what can happen. So if we're waiting and waiting and waiting, and there's something that you can try, but they just want us to wait, can I just say no? I want to try this now. What's the line with that? I know that there's reasons why they want to wait it out and those kind of things, but when do you as a parent say, no, I want this to happen now to see if it makes a difference?
Correct. Yeah, I don't think there's any good timelines. In general, we have the most evidence for arthritis in terms of when medications start working. So if I'll give you some timelines about that. If I start a patient on methotrexate or one of those similar medications, the biologics, the fancy drugs, I know that maybe the patient will start feeling better in a month, but I probably won't see a difference in terms of their joint exam for at least 2 to 3 months. And so that may be part of it. If I look back to 10 years ago, I was in Belfast, Northern Ireland, and I was talking to one of the doctors there about how do you decide medications and how long do you wait? And 10 years ago is not that long, because we still had a lot of the biologic drugs. And his comment, because we were in a small group, was, well, it really depends on what the insurance is, because it's a socialized system. And he says, the way it works here is you've got to use, for whatever disease, you got to use methotrexate for 6 to 12 months before the insurance will allow you to use the biologics. So in that case, at that time, it was Enbrel, Remicade, and Humira. And I said, so does that affect your decision about how long you're really waiting? I said, because in the US, I know that if in general methotrexate isn't really working for arthritis in 3 months, even as long as 4 months, I'm already thinking, what's the next drug I've got to add to this regimen or switch to? And so at least for that case, it was they were waiting because the insurance dictated it. Now I know that in Canada and in the UK, there's the period that you had to wait is really shrunk down. So from an insurance perspective, it affects that. And if that, in the back of their mind, the doctor knows, like, all right, they've got insurance X, that insurance requires that they're on this drug this amount of time. And unfortunately, insurances are stepping into the realm of the doctor-patient relationship to change how quickly you can make it. There's not enough data regarding dermatomyositis in terms of when you should change it. I'm going to switch a little bit and tell you about homeopathic medications. And when a parent tells me, I'm going to go and I'm not going to use your drugs, and I'm like, I said, completely fine. I said, the reason I want you to try the medications that I think of as a sort of more Western doctor is, and I take homeopathic medication, so that's my disclaimer, but is because the evidence for your disease is blank, and this is when I think that they might start to work. But if you want to use them, and I'll go and I'll research them, I'm happy to do that and try to find out and say, all right, we can do that. So I think the expectation and in terms of why you want to change your mind or why your idea is different, you should let them know. Because I think it helps you to both understand, why does the doctor have an idea of why they want to do a certain treatment and how long they want to wait versus why does the parent want to do maybe a completely different treatment or no treatment, which I tell parents, all right, you can do no treatment, I can send you to get a second opinion, you can add homeopathic medications because again, this relationship is a marriage. And if it's not working, then we got to go get counseling, which usually means we probably got to spend more time in the room, probably without the child, so that we can figure out what's happening between the two of us. So I would just talk to your doctor specifically about like, I'm thinking X, and you're over here in Mars.
Well, specifically, my daughter had a flare in the summer just on her hands. That's been the only flare. And so they did mention IVIG at our last appointment in December, but they said that they won't decide that for 6 to 12 months. And she's on methotrexate. We've gotten off of prednisone, and her blood work is totally fine, but they don't want to try that for 6 to 12. And for me, I'm thinking, well, if it's going to quiet the disease down in her body, let's do that now. So they said we won't wean her off methotrexate at all for at least a year or two just to make sure it's quiet and it's down and all that. So I'm just wondering if, can I just say, hey, let's try IVIG and see how she does. That's kind of where my concern is. If they want to try in 6 months, let's try now.
Correct. And I just had that interaction with a family, and they kept saying, I want to be on IVIG. And it wasn't until the second visit when I sort of found out, really, why did you really want to be on IVIG? Because your son is doing excellent, and we've been able to go down really low on steroids. We haven't had any therapy. And really what I found out was their son was beating up their daughter, and so they're thinking, maybe if I add this other drug, the beating will suddenly decrease or stop. And really what it was is IVIG is not going to do that. It's the steroids. The steroids are really what are driving your child's mood. And this is a little kid, I'm not going to give you the age, but your child's mood is due to the steroids, and adding IVIG won't make the mood better. It is the decrease into the steroids. So in terms of the skin condition for dermatomyositis, it's one of the sort of the last things to go away. So it likes to rear its head first.
It did go away until the summer, until the sun hit, and we did everything we could, but just on her hands. Not on her knees, not on her eyes, not on her feet, nothing. Just on her hands.
Correct. I would just try to go back to have the conversation. Perhaps they're thinking that, the muscle enzymes are normal, or maybe the rest of the exam is normal, and maybe this is just only skin. Because usually what we do is we try to find everything possible to try to find evidence of muscle involvement so that we can get more aggressive in terms of therapy. We had a meeting, I think it was about 2 years ago, for CARA. And with CARA, we were talking about juvenile dermatomyositis without muscle involvement, so when they only have skin involvement. And I think the biggest message was, look as hard as you can to try to find any evidence of muscle involvement. Why? So that you can be more aggressive. It makes it easier to be more aggressive in terms of therapy. So I would just say, go back and try to find out, well, why not? Why do I have to wait such a long time?
Okay. That's good. Thank you.
Any other questions? Otherwise, we start picking names out of the straw hat. And Jesse, you were with us for a very long time. Do you have any questions about what you perhaps thought did or did not work? Or comments?
No, actually, we didn't have a point. And he still wanted to stay there, but he turned 18, so he didn't want to go to another doctor.
Yeah.
It was great.
I was sad. It was sad because I remember seeing Jesse for a very long time, and even though he wasn't my patient, just seeing him there, he was like this ninja. Suddenly he'd be in the back getting therapy, and suddenly he'd be walking around, and if you weren't careful, Jesse would be smiling. So it's always nice to see Jesse, and he's really changed over the years. So. Any other questions? Can I tell you some things that are useful as a doctor in terms of preparation for visits? In April of last year, one of my patients who was going to turn 18 later on that month came and told me, "All right, doctor, Dr. C, I'm done." I said, "What do you mean you're done?" "Well, I'm done with you. I'm going to be 18, and I don't need to be coming to this room where there's all these Mickey Mouse and all these kind of kid pictures. I'm all grown up." I said, "Oh, okay." I said, "Well, what do you plan to do?" He says, "Well, I'm going to find myself an adult rheumatologist, and I'm going to find myself an adult regular doctor, a primary care doctor, and then I'm going to move on." I said, "Okay, well, you're still on lots of medications." And I said, "What else do you plan to do?" He said, "Well, I'm going to move out of my house. I met a girl last month, and we're going to get married." And I said, "Oh, okay." I said, "So do you have a job?" He's like, "No." I said, so you're planning to go see an adult rheumatologist, an adult regular doctor, you're going to move out of your parents' house, you're going to buy a car, and you're going to move in with this girl that you just met a month ago, and you're going to get married?" He said, "Yes, absolutely." I was like, "Okay. We got problems." I said, "You don't have a job. She doesn't have a job," I found out. And I said, "So how are you going to buy the ring, pay for the wedding, buy a car, get a house, pay for your medications?" Because he says, "I'm going to get off my parents' insurance because I'm going to prove to them that." And I said, "All right, I guess I haven't done a really good job in terms of preparing you for the world, because part of this growth is us together." And so I said, "All right, I'm going to ask you a really simple question. Why do you come to see me?" He's like, "Oh, I don't know." I said, "All right, what disease do you have?" He's like, I don't know." And I said, "Okay, do you have any idea the medications that you take?" "I don't know. I get some shots and some pills that you give me." I said, "All right." That's when I realized that I had failed him. I had failed him as his doctor and as really sort of his colleague in this chronic disease. So he had arthritis. He was taking methotrexate, folic acid, and a couple other medications. And what we ended up doing is having to call our social worker to really try to help him. I saw him one more time after that visit, sort of just to help really wrap things up. And I brought in the mom separately, and I said, "All right, we've got problems." And what we did is we met with the mom, the dad who, in I think the 5 years that I knew him, came once. And we said, "All right, we do need to do a better job." So we ended up helping him not to get married. We ended up helping him stay with the mom. We helped him find an adult provider. He stayed on his mom's insurance so that he can pay for his medications. And a few months later, the mom called us and says he's doing so much better. He's actually working now. He's learning to be a chef. And so it wasn't all pretty, because it really said that part of that doctor-patient relationship, I didn't do a very good job. As a result of that, we created a transition program to try to do a better job to help our patients prepare, whether it's going to go see a new doctor or get a second opinion or go to the adult world. And the reason I bring that up is because part of this long marriage that we have with patients or people is that we both need to understand each other. And part of understanding the other person, so that when you're on the other side, is that have stuff ready that you need. If you can't remember the names of your medications, take the bottles, as long as they don't have to be refrigerated. Or take the medications that you're having side effects, because if you don't remember the name. Take whatever questions you have to that doctor's visit. And sometimes what's really helpful is if you prepare us to say, I've got a long list. I remember I was with a family, and we've been in the appointment. This is probably the fourth appointment. It was about 45 minutes into that appointment, and the dad said, "I have 2 more questions." I said, "Okay, 2 more questions." I said, "Sure." He opens up this folder, and he takes out 2 pieces of paper. And I said, "That's not 2 questions. That is us meeting during lunchtime to go over these questions." So he had in there about 50 questions on those 2 pieces of paper, just to give himself enough space so he can write questions. But I thought it was really helpful to understand what questions he really had. And so I think if you can come prepared, whether you're going to go see the doctor for the first time, you're going to go get a second opinion, or you're going to go back to that visit. Because even though we're on electronic healthcare records, I may not get the records that your primary care doctor. A lot of times patients are going to see me like, well, I saw my primary care doctor, we had strep, and they sent you records. And I'm like, all right, let me look. I'm like, no records. I'm equally as fault. So I think being prepared. So if you know you've gone to go see another doctor, whether it's for second opinion or you were sick, always try to make sure that those records get to us, because it helps us to be prepared. Like, oh wow, you were sick, or hey, you need surgery. We need to figure out when you stop your medications. So being prepared in terms of making sure those records make it to us, or making sure that the labs make it to us. There's a little rule that a little law that went into effect about, it's almost 3 years now. In 2014, the government decided that patients need to have access to their information. And so what it says, if you go to lab X, any lab that you go to, you can call that lab a few days later and say, I want a copy of my labs, and you can get a copy of them. No, not many people know that, but it's very true. And so if you know you're going to go see someone else and you've gone to the same lab over and over, then if you know that we never get the labs from the other doctors, bring them. Go to the lab and tell them, because by law you have right to those labs, and so you can bring them. So as much as you can do to get prepared for the visit, whether it's with questions, whether it's lab results, a doctor's visit that you went to, or a specialist that you went to go see, it's really helpful. If you went to physical therapy, I can't tell you how many, I love sending patients to physical and occupational therapy, but it's really uncommon for us to get those notes consistently. There's a couple places where we get those. So if you're going, make sure that place sends us those notes, because it tells us stories like, all right, all that stuff that happens in between the visits, if they never send it, I don't know. It's almost as if it didn't happen, right? So being prepared is really helpful for medications, your questions, your medications lists. And with that, when you leave the doctor's office, if you're someone, especially if you've sent your husband to go to these appointments, or you sent someone else who's maybe not as used to going, to have those better conversations, make sure that you leave with patient summaries. Part of electronic healthcare records, we now have the ability to print out a summary, and that summary usually says your diagnosis, the medications. This is something that the government really wants us to do. And if you have a portal, which I know I'm not a big fan of portals, but they're there. The way it works for our notes is, and the way it's supposed to work for all doctor visits, if you go, and I don't know if Canada's the same, but when you see your doctor, the next day, the notes have to be in there so that the patients can see them. So I've pushed really hard, because one of my other jobs that I do is electronic healthcare records, is push our physicians to say, get your notes in there. People are going to look at these, and you need to send a good message to try to finish them within 24 hours. Because the way that I pushed to get our electronic healthcare records is, if I see you at 8 a.m. or I see you at 8 p.m., the next morning by 8 a.m. the doctor's note is in there from the patient portal. The labs we try to do is we try to push them also to the patient portal so that people can see them and they can have informed decisions. We've only been doing that for the last 2 years, and if I look back when I was in Cincinnati in 2012, they had a patient portal, and they had that ability. Everybody else is behind the game in terms of doing that. So again, before coming to the visit, have all the information or questions that you have. When you leave, try to get some of that information, because it sort of serves as a reminder. Maybe someone else, maybe the grandparents went to the visit, and mom said, "What? I know they were going to change the medications. What was it?" So there's not a guessing game. Any questions, comments? Any other things that didn't work, whether it's my clinic or any other clinic? Because I think it's helpful to hear that.
But one other issue that we have is that you get a doctor that you really like, the doctor that's treating you on a regular basis, but you have trouble getting through to their staff. The staff is the lord of the records.
Correct.
So you love the doctor, when you get the time with the doctor, it's all great, but then you leave and you've got to deal with the next in line, and that's not desirable. So you may or may not get the records. We have the big doctor that requests the reference ranges on the blood work, and then they act like, reference range, doesn't she know what an aldolase is supposed to be? And so you get this kind research doctors for Cure JM on a 6-month basis as second opinions or to see what's going on. But then we come back to our local doctors and, you know, there seems to be a little bit going around. Do you have any suggestion for that? Is it easier doctor to doctor? Is it, you know, because we get caught in that, of not getting exactly what this doctor requires is not what this doctor requires.
Correct. And what we did for, when some of my patients started seeing Dr. Pockman, what Dr. Pockman and I did, and it wasn't very easy, is patients would go see her, and then I would give patients a lab slip and say, all right, if you go see her, within a week, I would really like for you to get labs done at the facility where you're most likely to get your labs. So we can see how close those labs are, because then we can get a better idea. And I did that with Dr. Pockman just because I know she keeps really close tabs, and unfortunately she's really getting closer to retirement, in terms of following the labs. And that's worked out really well for us in terms of that. One thing that we're trialing out at our clinic, and I wish we could do it the way my friend from DuPont did it, is he was in charge of the patient experience, the safety and quality for his hospital. And part of what they did is he got it allowed through his hospital, and it's not allowed at our hospital, but he got it allowed so that his patients could email him and text him. And the patients were really nice because they knew that they would try to text him between like 8 a.m. and 8 p.m. And so what he found, and he published this, is that if the patient can get more direct access to the doctor, and it also included with the staff, by just electronic messaging as opposed to, I'm going to hold online, that what the conversations that normally would take up 20 minutes of waiting, and let me just tell you the story again, was easier to tell just by sending the message through the portal, the email, or the text. And so his patient satisfaction scores were super high because of that. And so part of what we've been testing with our patients with the Arthritis Foundation is getting them to send us messages through the patient portal, so that it allows us to know, like, okay, all right, we can answer this question, like, yes, you just need to get your labs in a month, or you need to just to do blank, or no, we haven't gotten this information, and that takes literally minutes, as opposed to if you add up the amount of time that it's going to take you to get on that phone, patch through the two different numbers is much longer. So that's something that we're trialing. And other things that we're trialing to try to send more information is we have an electronic healthcare record that if the providers want to be able to log in, if they're on the same type of EMR, what happens is we can share records a lot easier, and it's able to share that. And part of what we're going to be doing now, we're only doing this for primary care, because we've made so many missteps with that one, is we're going to allow the primary care doctors to make appointments into specialist appointments. And we're also going to make it so that this phone thing, what happens is they download an app. That app in a HIPAA compliant, meaning that it's covered, health information is protected. What happens is the primary care doctor can send us that information. They can even send us a picture. And once we get that right, the plan will be is that the patients can then get on that HIPAA protected. So there's a picture they need to send us or a message they need to send us, they can send it to us electronically. Again, we've had a lot of missteps with that. So what's happened is we're trialing it first with primary care into specialty appointments, ERs to make appointments into our offices, and then the next step is the texting system. We have turned on the application function in terms of being able to text. Now what we're testing right now in Austin is the ability to send pictures, so that if your primary care doctor is seeing you and says, look at the rash, they can send us a picture and it's protected. And then the next step will be, how do we get patients to be able to send us that message? Because my colleague proved they can get direct access to you or to your staff as opposed to a bunch of numbers. Everybody's much happier, and you get answers, questions to answers much faster, answers to questions much faster.
That would be great, but at Tulane in New Orleans, they don't even have a portal, so that's what we're fighting. And there's not very many pediatric rheumatologists in Louisiana. So, that's the kind of things you're fighting too, is that there's, only a couple of choices in Louisiana for pediatric rheumatologists. We live about 50 miles from there. So we travel to New Orleans to see The doctor, she's great, and she will work with Pachman or Reed or whoever we go to. She works with them, but she's not on a portal. It's not part of a whole clinic. It's not part of a whole care. So, she goes to the doctor in New Orleans. She goes to IVIG in Baton Rouge at the hospital. So we have to have an immunologist that prescribes that, who really has nothing to do with her case, other
Correct.
than a favor to prescribe the IVIG so we don't have to go to New Orleans for it. So coordinating and getting all of those records where it needs to go is a never-ending nightmare problem.
Do you know how that was created? The lobbyists for electronic healthcare records said, I don't want to share my data. And they lobbied hard enough that they were able to get it so they didn't share it. Why? They were concerned that if they were able to connect, people would be able to look into each other's systems, and there would be no need for competition. Because if you're not the Epic and Cerners are the big electronic healthcare records. And so what they were able to do is fight enough or lobby strong enough that they're not connected. Now the government's like, oops, we did it wrong.
You did it wrong, because now the no connection it's just so incredibly difficult. It puts a lot on us, and then you really don't have anything we don't have anything to fight with. So
Correct.
you say, I need this, and so then even further, they send those Aldolase goes outside of the hospital, and so that's from the hospital.
List of lab results, but no reference
No
range for the
reference
out-of-state doctor. And when I call the hospital medical records,
If you use the mic.
when I call the hospital medical records, they won't even release the fax number to me because I'm not important enough. And so the people at Duke have to, and then at the bottom line is they still didn't get it all. So it's a nightmare to get.
Yeah, so what I would try to do is usually try to find someone in the clinic who's sort of you're in. So if Jane Doe in this clinic is the one, then usually what we do that. I have the same situation in terms of I have, for my patients that live in San Antonio, which is 70 miles away, what I do is I have an immunologist who, and it took a long time finding it, I have an immunologist there for people, for everyone except for military. And in the military there in San Antonio, I have a military physician. And what I do is I write the orders, I leave it blank, I give them the orders, they fill out their signature, and everything gets done. And what they do is they email me electronically in a HIPAA way. HIPAA controls that data. What it does is it sends me the information. And so what we did at the same time is we said, all right, the next time you go to this person's lab, I need you to also repeat it in a week. I said, I know it stinks, but it gives me an idea of how close those reference ranges are in terms of the lab that I'm using. And so by finding that as I found an immunologist in San Antonio who will email me, will call me, will text me in terms of like, hey, I'm seeing these issues, what do I need to do next? I think you need to see them sooner. And the same thing I did in San Antonio for the military patients, and it allowed me to have someone that I could connect to, because even as a provider, we have the same issues. So you've got to try to find someone who can get you your in to get you that data. So I know what happens usually if I go to the military doctor, about 2 days later, he sends me the lab results to say, all right, everything's back now. What do you think? And then the guy in San Antonio, he's been doing rheumatology for such a long time that he's comfortable doing the CMAS testing, or he's comfortable doing the joint exam. And so he'll just call me if there are any other issues, because usually what happens to those patients is they're getting their therapy monthly, but I see them about every 3 months. And then sooner, if that in-person helps us, and you have to find the equivalent in-person, whether it's a nurse or medical assistant, or we had, what was it? I had to get a sleep study done on my son, and it took my wife 3 weeks to make that appointment. And my wife was a nurse at that hospital, knew all the people there. So eventually what she did is she's like, all right, week number 2, she drove to the hospital. She went and talked to the woman who would actually return her calls and said, all right, I'm going to help you. And so that woman said, all right, this is the form that we normally get filled out, and this is what you've got to do to send it to the other person. So she gave us that fax. So she was our in to do it. She was a completely different clinic, but that was the only way we got that sleep study scheduled. And I had to go to my colleague and say, all right, your system for getting a sleep study stinks, and I'm going to tell you why it stinks. I said, because it doesn't work. I knew enough of the people on the inside to be able to work it, but it shouldn't be that way. Imagine all the people who just give up and don't get that stuff done.
Yeah, we've recently considered and can speak to her doctor in New Orleans about possibly just doing the blood work at her clinic, bypassing Baton Rouge, and drive to New Orleans to get the blood work per month if she will coordinate with Dr. Reed, who we're seeing now. So if she would coordinate that, then, we would cut out some of those steps and maybe, but I really like your idea of finding a person somewhere, if it's in Reed's office or Eldor's office, that will champion that for us and make sure it gets where it's got to go. It's just finding that.
So we had a lot of issues getting labs to providers. That if I ordered labs where I ordered imaging, what would happen is the patient, their parents would go to the lab, they would go to get imaging done, and then the primary care doctor, who should be informed, wasn't getting it.
Yeah.
And so the pediatricians in Austin got together and said, your group of subspecialists are terrible about keeping us informed. You send us your notes, of which 4 pages stink. I can only read one half little page about what's happening, but I don't get the results. So what we did in our electronic healthcare records, and I apologize if you don't have that, but what we did is we created workflows so that what happens is we would make sure that if they have an immunologist or have some other specialist, and definitely the primary care doctor, they were CC'd and they get a copy of it. But the easiest way to do that is by getting, when you go get your lab or when you go get your imaging done, is make sure that you tell the lab, this other doctor, this is their name, and this is their fax number. You need to do it. And by law, they have to, because you're basically telling them, I'm signing up for you to give this information to the other people. So what I would do is, if you can get out the other lab, is try to make sure that you have, Ann Reed's, full name and her fax, so that by law that lab has to send that information to the other doctors, even if it's in another state.
Okay.
We have several levels. We go to a hospital, the hospital takes the blood, and then she has a doctor in New Orleans, and then Dr. Reed, and, so it's multi-steps.
And the immunologist.
Right. So when the blood work comes in, the immunologist gets it, I guess, and sends it to Eldar, but it's never the full story. It's just the results. So without the reference ranges. So that just seems to be like the hardest thing to get seriously. People do not want, it's a state secret.
It's Louisiana.
We cannot allow, anybody to know here's the results, but I'm not going to tell you what they mean.
Correct. Yeah, that's a very broken system. If you ever get the chance, if anybody ever gets the chance, and I talked about this yesterday when we talked about the patient experience, is I think there's several books that are really helpful for us as providers that we need to read. And one of them is If Disney Ran Your Hospital. So it tells you to think about it in a completely different way. We're taught, I'm the doctor, I'm in charge, I'm the smartest person in here, I know what I'm doing. Who are you to tell me or to question me? And it's terrible. In my medical school, what happens is, in month number 2, we started seeing patients. I was as clueless as you could possibly be and as dangerous as you could possibly think I am dangerous by seeing patients in number 2. But I was just really asking questions. I really wasn't doing stuff. And that way we learned. And we got evaluated. Every day we got evaluated by each other. We did 360. So the patient evaluated us, the other people in the room evaluated, and we evaluated each other. And I remember thinking, oh, this is painful. We're never going to get done. But the way the classroom was structured is we were out by 12. We had a 2-hour session twice a week. And then one afternoon is we were seeing patients. And it was really nice because the way that we were graded and the way that the students from the University of New Mexico were graded, they had some of the highest gradings for their interactions with patients, because you were forced to, on a regular basis, get that comments live in terms of like, you did this wrong. You should do this here. You didn't shake my hand. You didn't look at me in the eye. And it was really helpful because it reminds you of sort of the cotillion. Has anybody ever taken cotillion class? When you go in there, you got to shake their hand, look them in the eye, not the dead fish, don't ignore the other people. So these common themes that sometimes we forget. So one thing I will warn you that's happening in medicine is physicians are being measured to death. And hopefully what happens is we do a better job of measuring physicians and measuring outcomes and measuring the experience, because we're not doing it. Because remember I talked about earlier, the way that the measurements were created was for risk management as opposed to the really experience. And the afterthought was quality. And so right now what's happening is in medicine is because there's been such a big change in the landscape of medicine, and I don't just mean because of the election, I mean, well, in the last 10, and especially in the last 5 years, is physician burnout is the highest that it has ever been. And so I think it's getting heard is important, and understanding that you need to understand the physician as well, because I think sometimes what happens is we go in there as physicians thinking that you're going to dictate what's going to happen, and the reality is the patients really need to dictate that, because there's all this other stuff that happens outside the appointment that really trumps everything else that happened right there in that 15 or 30-minute visit that really will decide, are they going to take medicines? Are they going to come back? Are they satisfied? And so hearing that is really helpful. And so if you don't, I think one of the first things that go away when the physician is being burnt out is empathy, because you start to lose that connection. I was at a leadership conference for the hospital system, and at that hospital system, what they did is they asked 3 questions, and I don't remember the 3 questions, but they were really 3 simple questions, and they said, I want everybody to be honest, and it was all the leaderships in different hospitals, and they said, they're asking questions about how you felt, and they said, all right, how many people in this room answered yes to number 1? And I would say about maybe 20% of the room answered that question. And he said, you're burnt out. And he said, that's the next question. And I can't remember, and I don't remember the questions, but the message is really strong. He said, all right, how many people answered yes to number 2? And I would say about 80% of the room raised their hand. And he said, he says, you're really burnt out, and you really need to get help. And then when he got to the 3rd question, he said, how many people felt this way? Don't raise your hand. He says, because if you feel this way, you're depressed and you really need to get help. And so the message from that was that it was amazing to see that when people were really honest in medicine, that 80% of these people are either headed towards burnout and depression or already there. And so what he did is, and I really suggest you get on this website, is he had that group of us go to his study, and he wasn't really promoting it, other than he says, people who get depressed get put on all these medications, and it turns out there was some studies done in the 1980s looking at outcomes for patients with arthritis, and it showed that if the mom is depressed, if the mom has maternal strife, however the mom perceived maternal strife, remember the moms are the pilots, then the outcomes for those kids were poor. It didn't matter how bad the disease was. It didn't matter how much in terms of medications that you did. The mom being depressed, the pilot going down really controls that plane and where it's headed. And so if in medicine, if you think about with your physicians being burnt out, it's hard to get that connection because they're losing the empathy. It's hard to sell that message because they're not doing that. So if you see that, try to work with your provider, because again, I think we've reached a point in medicine where so many physicians are really burnt out and don't necessarily enjoy it like they did when they went into it. And so the website is called, if you look up Duke Research and you look up 3 good things, it leads you to this place where you send a text message, it sends it to you back, and it asks you a couple questions like your name and your gender and where you work or what kind of work you do. And what it does is then it then texts you back every morning or every evening. It'll text you 3 messages. And what you do is you focus on these 3 messages. Say, all right, I'm going to say hi and I'm going to smile, or I'm going to make sure that I start my day off, I'm going to have a good breakfast. And so you focus on these 3 things. And what they found was that they were just as effective by doing these 3 things, focusing on these 3 positive, either ending your day with these 3 positive thoughts or starting your day with these 3 positive stuff. Just as effective, if not more, than people who went to get cognitive behavioral therapy, meaning talk therapy, and or using antidepressants. So what it's saying is that don't forget the goodness in your life. With that, I went, as part of that lecture, what they did is they talked about how certain memories stick. And what they did is they took healthy people, they deprived them of sleep for one night. Does anyone want to guess how much of their memories they forgot from one night of sleep? Just one. Any idea? Remember, these are regular healthy people. They're not necessarily on medications. Any numbers? 50%? Any other guesses? 80? 40%. If you deprive a normal healthy person of sleep, they will forget 40% of their new memories that they just learned. If you give them positive thoughts, they will forget 60% of those positive memories. If you give them negative thoughts, they will remember them. So, what does that say? It's the front of our brain that really is. He was talking about this lecturer. What was his name? Brian. I can't remember his last name, but he was amazing. He was talking about how, it's a front part of our brain that, when if you're the parent and you're like, I want to slap this doctor because boy, he's so full of baloney, right? But you don't say it. You may think of it. Your face may say it, but you don't say it. And so it's also in terms of determining, sort of how we act in terms of our interactions. And there's a different part of our brain that's involved in memories. And that's linked closely to protecting ourselves. So if we think back to, when we were dragging our knuckles because we still hadn't gone through that, and that's usually men before 30. Then what happens is we have a protection. We protect ourselves by remembering those negative memories. So by having those negative interactions, patients remember that. All right. So 3 good things. Try to go to that. So if you look up under Duke, the way I found it, because I forgot it, was let me see if I can remember, because it was a number. It was really amazing. Let's see. If I don't find it, what I'll do is I'll look for it. Okay, here it is. It's you send it. The phone number is 73940, and you text @ the little @ sign 3G as in good, T as in things. So the phone number is 73940, and then text in the subject, type in @ the little sign @ 3GT. And then what happens, it'll text you a link to a website. It's called the Duke Patient Safety Center Survey. You click on a bit link, and then you put in your information, and it sends you three powerful positive messages. Any other questions, comments, requests, or dedications? All right. Well, thank you for coming. It's always great to see people outside of the 4 walls at our clinic, because I think it sort of sells the humanity that we're people just like you. And if you want to remember that, just hang out with us at functions like this, because I think it's nice. You're not worried about the medications, and we're not worried about did you take them. We're just hanging out and having fun. All right.